what happens when the exact science of death is simply wrong. When a heart monitor flatlines, doctors don't just guess. They follow a rigid, clinical protocol. They check for pupillary response. They listen to a silent chest for a full 60 seconds. Only then is the time of death officially logged, and the face covered with a sheet. At that precise moment, the biological machine has permanently shut down. But in a terrifying handful of highly classified medical case files, patients who were clinically deceased, left entirely alone in cold, silent hospital morgues, did the impossible. Imagine being a night shift nurse tasked with a routine body transfer. You step up to the stainless steel drawer, you reach out to verify the toe tag, and then, from beneath the heavy white sheet, you hear it. The unmistakable, ragged, desperate sound of a human lung suddenly gasping for air. This is not a paranormal urban legend. It is a strictly documented biological anomaly that modern medicine still cannot explain. They call it the Lazarus Syndrome, and it proves that the line between clinical death and the world of the living is not a solid wall. It is a terrifyingly thin, fragile veil. To understand the sheer panic this anomaly causes behind the closed doors of the medical community, we have to look directly at the raw, unredacted case files. We begin with case file number 1. The timeline of this event is what makes it so deeply, fundamentally, unsettling. A 60-year-old patient is rushed into the emergency room after suffering a catastrophic widowmaker heart attack. The medical team does exactly what they are trained to do. For 45 grueling minutes, they administer relentless chest compressions. They push multiple rounds of synthetic adrenaline directly into her bloodstream. They deliver severe, high-voltage shocks from a defibrillator, trying desperately to force the heart back into a rhythm. Zero response. The monitor remains a flat, unbroken green line. Her pupils are fixed and heavily dilated. She has no gag reflex. There is absolutely no electrical activity in her brain. At exactly 1:30 p.m., the attending physician steps back from the bed. The time of death is officially called. The chaotic room falls dead silent. The humming medical monitors are switched off. The invasive life support tubes are pulled from her throat. Her family is quietly brought in to say their agonizing final goodbyes. And then, the room is cleared. For over 2 hours, the patient lies entirely alone in the quiet, darkened hospital room, simply waiting for the morgue transport team to arrive. But when a ward nurse finally enters to prep the body and remove the remaining IV lines, she notices something physically impossible. The heavy silence of the room is broken by a soft, wet sound. The nurse freezes. She looks down at the bed. The dead woman's chest is rising, slowly, rhythmically. Fighting off a wave of sheer primal panic, the nurse presses 2 trembling fingers to the patient's cold, clammy neck. Underneath the pale skin, there is a pulse. A steady, undeniable, living pulse. By the time the frantic doctors rush back into the room, the woman who had been clinically deceased for over 120 minutes is not only breathing entirely on her own, she is beginning to wake up. This was not a misdiagnosis. The doctors had not made a mistake. The heart had completely stopped. The blood had begun to pool. The science of her death was perfect. So what restarted her biological machine in the dark? If case file 1 stretches the limits of biology, case file 2 shatters them completely. Because while waking up in a quiet hospital room is terrifying, waking up after the medical system has completely processed your death is a genuine psychological nightmare. This case involves a patient who suffered a massive respiratory collapse. Despite aggressive intubation and emergency protocols, his oxygen levels plummeted to 0. His heart stopped. He was officially pronounced dead by 2 separate attending physicians. He was stripped of his medical monitors. He was zipped into a thick, heavy, industrial plastic body bag. He was placed onto a metal gurney, wheeled down into the isolated sub-basement of the hospital. He remained inside that lightless, climate-controlled steel box for over 3 hours. It wasn't until a forensic technician arrived to begin the preliminary autopsy intake that the locker was reopened. The technician pulled the heavy metal drawer out under the harsh, buzzing fluorescent lights. He grabbed the cold metal zipper at the top of the bag and pulled it down. He didn't find a rigid corpse. Instead, he saw something that violently defies every known law of medical science. The inside of the heavy plastic bag was coated in a fine, misty layer of condensation. Dead lungs do not exhale warm air. The technician stared in absolute horror as the man inside the bag slowly turned his head. His skin was ice cold. His lips were entirely blue from the refrigeration, but his eyes were wide open. He had woken up inside a locked morgue freezer, trapped inside a sealed body bag, completely paralyzed by the freezing temperatures, silently waiting for someone to find him. How does a human brain survive for 3 hours with 0 recorded oxygen? How long was he awake inside that bag before the zipper finally opened? If 3 hours inside a freezing morgue drawer defies the laws of biology, our final case shatters the fundamental understanding of human death entirely. Within 6 minutes of the heart stopping, brain cells begin to permanently die from hypoxia. Within hours, blood begins to heavily coagulate, and cellular decay officially sets in, which makes case file 3 physically impossible. A female patient suffers a severe cardiac arrest in her home. By the time paramedics arrive, she has no pulse. She is placed on advanced life support and rushed to the ICU, but her brain shows 0 electrical activity. After hours of frantic, aggressive intervention, the medical team delivers the devastating news to her family. She is gone. The life support machines are officially turned off. The flatline alarm rings out. The time of death is recorded. The family, completely shattered, leaves the hospital to begin making funeral arrangements. The patient's body is prepped and left in a secure, climate-controlled holding room. 1 hour passes, then 5, then 10. At the 17-hour mark, the biological machine should be actively breaking down. The blood should be completely stagnant. The brain should be irreparably damaged, but at exactly 17 hours post-mortem, a nurse walks into the holding room to retrieve a piece of equipment. As she passes the bed, she sees the impossible. When the panicked medical team rushes in and hooks her back, up to the monitors, they do not find a faint, struggling pulse. They find a strong, steady heartbeat. Her blood pressure is stabilizing. But the most terrifying part, when the doctors perform emergency neurological exams, expecting to find a patient in a severe, permanent vegetative state from 17 hours of oxygen starvation, she responds, "How does a human brain survive 17 hours with 0 circulating oxygen? How does thick, stagnant blood suddenly decide to pump itself back through the veins?" The brightest medical minds in the world are forced to admit a terrifying truth. They have absolutely no idea what is actually happening. When a patient wakes up inside a body bag, the medical community cannot simply classify it as a miracle. They have to investigate. They have to find a biological mechanism to explain the impossible. In the official medical literature, they don't call it a resurrection. They use a sterile, highly clinical term, delayed return of spontaneous circulation, or ROSESE. And right now, medical science only has 2 working theories for why ROSC happens, and both of them are terrifying. Theory number 1 is the pressure cooker effect. When a patient is dying, doctors aggressively pump oxygen into their lungs using a bag valve mask. The theory suggests that in some cases, The lungs are pumped so full of air that they hyperinflate. This massive buildup of pressure acts like an invisible clamp, violently squeezing the heart. Because the heart has no blood to pump, the monitor flatlines. The patient is officially declared dead. The doctors stop CPR. But as the dead body lies alone in the quiet room, that trapped air slowly leaks out of the lungs. The invisible pressure releases. Suddenly, blood rushes back into the heart chambers and the biological engine violently jumpstarts itself. Theory number 2 is the chemical time bomb. During an emergency code, doctors pump massive doses of synthetic adrenaline, epinephrine, directly into the dying patient's veins. The theory proposes that because the patient's circulatory system is failing, that adrenaline doesn't reach the heart. It gets trapped in the stagnant blood of the peripheral veins. It sits there, entirely dormant, while the patient is declared dead and wheeled down to the morgue. Then, hours later, as the stagnant blood slowly shifts and settles inside the corpse, that massive dose of adrenaline finally reaches the heart muscle. Like a delayed explosive, it detonates. Both of these theories sound perfectly logical on paper. But here is the dark, unsettling truth that the medical community does not want to broadcast. These theories are entirely hypothetical. The terrifying reality is that when it comes to extreme cases of the Lazarus Syndrome, science doesn't have an answer, which forces us to ask a much darker question about the nature of clinical death itself. If the science of death is not an absolute wall, but a gray area, then we are forced to confront a truly horrifying possibility. We know about these specific case files because these patients were lucky. They woke up while someone was still in the room. They woke up before the morgue technician went home for the night. But what happens when the chemical time bomb goes off or the pressure cooker releases just a few hours too late? What happens when the biological engine finally jump-starts itself after the morgue locker is permanently locked? Or worse, after the burial? The Lazarus Syndrome isn't just an unexplained medical anomaly. It is a terrifying mirror held up to the limits of our own scientific arrogance. It proves that despite all of our monitors, our rigid protocols, and our absolute certainty, we still do not fully understand the exact moment the lights permanently go out. Now, I turn the case file over to you. What do you believe is actually happening in these cold rooms? Is this an undiscovered biological failsafe, a final, desperate survival glitch in the human machine? Or is our fundamental definition of clinical death simply wrong? Drop your theories down in the comments below. I read and reply to every single one. If you are fascinated by the anomalies science cannot explain, make sure to hit that subscribe button and turn on the notification bell. This is CaseHush, Dark Cases, Missing Answers. I will see you in the next deep dive.